Hello, everybody. It's my pleasure to have here Dr. Eric Verhoeven. I think that he doesn't need any introduction. He's a really well-known vascular surgeon. Hello, Eric.
Good morning.
How are you doing?
I'm doing fine, thank you.
It's an honor to have Eric here in the city with us to share just 5 minutes with some questions. The first, something about your topics here in the city, for example, about the complex cases, about the advanced technology, for example, like in the dissections treated by endograft, by branch endografting. Do you think that these techniques need to be improved? I mean, with the grafts or with the bridges stents, what do you think that is the immediate need in the graft, in the bridges stents?
Well, thank you. From the technical point of view, we have to realize that these are advanced and very complex pathologies that need advanced and complex techniques. So it's not open to everybody. It's really teamwork, and the technical evolution will never stop. So we will always see new additional techniques. We will always see better grafts. We will always see better stent grafts, bridging stent grafts. I think at this moment, to treat these patients, we have very good stent grafts, with Cook, of course, being the first on the market with these branch stent grafts. Other companies are coming into the game, which will only develop the game again, which will improve all the systems, also the Cook systems. And I agree in your question. I hear something about the bridging stent grafts. I think we may do with better bridging stent grafts, but I know the companies, for example, Gore, but also Atrium Mackay, are working on improving improving their own bridging stent grafts or creating new stent grafts.
Okay, but when we are talking about complex cases, advanced technique, do you think that everybody can perform this kind of cases, or it's important to have reference center, or you need to be slowly, step by step? What do you think about it?
You know, when you really take on the most advanced cases, which are obviously the thoracoabdominal pathology, and that you want to treat those with fenestrated and branch stent grafts, sometimes combinations, you deserve to have the perfect setup, because it's about logistics, it's about organization, and it's about details. So the first thing you need is a perfect setup in terms of hardware, which nowadays we call a hybrid suite. That's one prerequisite. The other prerequisite is that you need a lot of materials, a lot of backup materials, to be able to move from plan A to plan B to plan C. And the last thing, unfortunately or fortunately, is that together with the whole team, because it's really not something for one person, it's really for a team effort. Within that team, it would be nice to have a high volume so that the team can build on experience. So yes, if you look at these three prerequisites, maybe the hardware and the backup materials, the team and the volume, you realize that we should probably centralize those difficult procedures.
And what about the open surgery? Because do you think that the same centers should perform the endo and also the open, or probably in the future, the centers performing the open cases is going to be in other centers?
Yeah, well, ideally, I think you should have very, very big centers that perform both strategies or both options. In real life, in practice, I think we will see, or we see, more centralization now in open surgery than in endovascular surgery. And I don't think it's perfectly, or it's absolutely mandatory to be able to perform both techniques with a high volume. I must say quite honestly that in our center, the volume of open surgery in these advanced cases goes down, because we can do more and more by endovascular means. I'm not saying we want to do anything or everything by endovascular means, but overall we create more options, we get more possibilities, and we do more and more by endovascular means.
Okay, and we know that, but probably the patients doesn't know nothing about that. So how do you think that they should decide the center? Is a political topic, or the medical, the surgeons should be more involved in the information for the patients in the news and some platforms? What do you think about it?
Well, the ideal world involves free choice for the patient, but I think politically and financially this is sometimes difficult to organize. I do believe in a consensus, a compromise, cooperation. For example, I'm working in a very big center, but I'm not afraid to help a lot of smaller centers with their cases. If you look at the 3 levels, standard EVA, every medium-sized vascular center should be able to do that. But if you move to the next level, which is fenestrated EVA, double and triple fenestrated EVA, I think most centers should be allowed and could be doing those cases, maybe with some help in the beginning or with continuous help of more experienced people. And I'm providing that help with a lot of fun, and I'm happy to help them. For the most difficult cases, the highest category, there you really need, as I said before, all the prerequisites to be met, including volume. So those cases should be done in the high volume centers. And I hope that with this cooperation between surgeons in high volume centers and surgeons in lower volume centers, vascular surgeons of course, that the guidance of the patients towards the correct center for the treatment of their aneurysm would be kind of automated or logical, without having to force anybody, you understand?
Yes, but for being honest, I think that then we need to show our results to the patients, not only in our congresses or meetings.
Yes, but you know, the internet is a powerful tool, and I think results are more and more out in the open world, also for the patients and the GPs to take. In addition, the patients inform themselves via the internet. I'm always a little bit afraid of having your strict results out in the world, because the results may be colored by the difficulty of patients that you treat. For example, we get the most difficult patients to treat. If a smaller center or another center is really selecting, cherry picking their patients, they may have better results. So the only thing I want to say is that we need to be a little bit careful with putting all our results on the table, but transparency and openness is really the way to go. How you do this and how you handle this is maybe a different matter.
And finally, about the information for the patients, again, about for example, the aneurysms, where do you think that the medicals, the surgeons are the responsible for the information in the internet or in interviews like here, or do you think that this information should come from the industry?
No, I think the vascular surgeon should be the primary physician that informs the patient. An aneurysm is a strange thing. It's an enlargement of a vessel which is usually completely asymptomatic. So the patients don't know it, have no problems with it. So most of these patients are diagnosed by coincidence because they go to another doctor and the aneurysm is diagnosed on the way during that evaluation.
And sometimes it's the first time they listen aneurysm.
Exactly.
It's not like cancer that everybody knows.
So what we need, absolutely. So what we need to understand is that when we indicate this aneurysm for treatment, we really have to make a balance between the pros and the cons of the treatment and the risk of rupture. Aneurysms have a higher risk of rupture when they are bigger, but any surgical intervention, both open and endovascular, have a risk. So we need to carefully inform the patients not only about the timing of a procedure, and then also the choice of the procedure. And I don't see endovascular and open surgery as being in competition with each other. I see them both as a very good technique to treat aneurysms. And our role, our task is to really choose the best solution for the patient and not for the doctor.
Okay. Thank you very much for your time. It was a pleasure for me. Thank you, Eric.
You're very welcome. Thank you.